I want to welcome you to the fifth and final lecture in this year's Psychology Department Speaker Series. We appreciate the support that you have provided, those of you who have been to multiple sessions. It's really worked out very well for us. Just to let you know, we intend to continue the series next year for those of you who are still around. For those of you from the community members, you are always welcome. We appreciate you having here. And for those of you who are transferring out, if you still are in the area, look to the website and you'll see the topics that we're going to be bringing in knowledgeable experts in the area of psychology to share what they know with each one of us. The last person in our series is Dr. George Pommer. Dr. Pommer is a clinical psychologist with major Penning and Pommer. Dr. Pommer did his undergraduate work at Calvin. His Ed Specialist degree is from Michigan State, and his doctorate is from Western Michigan University. He began his career at Grand Rapids Public Schools, starting the first autism program in the area at GRPS. Most of his experience, most of his professional past has been in current work, is as a clinician. He specializes in areas such as ADHD, depression, anxiety, and psychological testing. So I invite you to give Dr. Pommer a warm welcome.
Thank you. Today I'm going to talk about ADHD. I'd like to begin by talking about some of the issues that are behind it, the causes, diagnostic criteria, or how we make the diagnosis. And as we're going along, if you have some questions that are really on your mind at that point in time, raise your hand. I'd like to do it that way. There will be a period at the end of the discussion for questions as a whole. Attention deficit disorder used to be called, or attention deficit hyperactivity disorder used to be called attention deficit disorder. And when I first was in training or getting my doctorate, it was called there were two types: attention deficit hyperactivity disorder with hyperactivity, and attention deficit disorder, forget the hyperactivity, without hyperactivity. And in fact, I did my dissertation on this. It seemed to me from the clinical work I was doing that there was always some level of hyperactivity there. Okay? Even when I'd try to make this diagnosis, or I'd read the criteria for saying ADD without hyperactivity. And as time elapsed, and my research was one of the things that showed that, was that there is some level of hyperactivity. So it changed, the diagnostic criteria changed from ADD with hyperactivity and ADD without to three types today that we discuss, or that is present. The first type is attention deficit hyperactivity disorder inattentive type. And largely means that word, inattentive. So we don't see as much hyperactivity, as much motor activity, overflow of activity. You might see someone that has that will sit like this all the time, or like this. Be looking maybe at the teacher, maybe at the parent, but the inattentiveness is there. So we don't have the motor activity. Another type is attention deficit hyperactivity disorder, hyperactive type. And that, pretty self-explanatory. That's when we have a lot of motoric activity. We're always fidgeting or moving around. There's an overflow of activity in the brain. It's how the brain is working. It's doing that to our central nervous system. The third, and probably most commonly diagnosed type, is attention deficit disorder combined type. So we have some fidgeting, some movement, some difficulty remaining seated for a long period of time maybe, but pretty much constant inattentiveness, with the exception, some are able to do this, of things we're interested in, things that are highly interesting. What you can have in ADHD then is a hyperfocus. So becomes really frustrating to teachers often, is that they'll say, well, you know, this student, when we're on a certain subject, or if I'm talking basketball, or if we're doing this, that attention is just, you know, like a laser. But if it isn't that, or isn't something they like, they don't give effort. And it's typically, the majority of the reason is not giving effort. It's that at that point in time, I can't pay attention. I get distracted quickly then. One way to think about those three types is if I have an inattentive type, if we were on a spectrum of this is ADD spectrum, this is mild, moderate, and then severe. Your inattentive type is more in this area, okay? Your combined type, which is what we usually see the most of, is in this area. Severe type or hyperactive type would have more severity to it. If I have a high amount of hyperactivity, I'm definitely going to have a high amount of inattentiveness. That's the way it works. Also earlier, 20 years ago, maybe 25, it was felt that ADHD kind of went away when we became adults. That, or more than kind of, we outgrew it. Now we know from research and work that there is adult attention deficit disorder. We have had to have had those symptoms for any ADD. We have to have them before the age of 7. But that everyone doesn't outgrow it. About 60% of people that were diagnosed with ADHD or have ADHD will have symptoms as an adult, which means 40% really improve, and especially in the area of inattentiveness and hyperactivity. Hyperactivity, by the way, a lot of times we'll see quite a difference from the early ages, 4, 5, 6, to when you see it at 12, 13, it might have really slowed down, 18 a lot. And that's because we get, as we're going on, more maturity of the central nervous system. It hardens off more. One of the reasons for the hyperactivity in that is more of an immature function of the brain, that I'll explain right away, and then of the central nervous system. One of the questions I always run into is ADHD overdiagnosed? You know, it seems like I knew kids used to line up at the secretary's office, and when I was in grade school, seems like everybody has ADD, that type of thing. About approximately 8 to 10% of the population has ADHD, of the child population. In adults, it's approximately 5%. It's about 4.7%. So that probably sounds lower than many people would think. It seems like there's more people than that. But when you put some other numbers in perspective, I think it makes a little more sense. Most of you probably know someone who has diabetes, relative or friend or yourself, grandparent, whatever. That affects 7% of the population. So it would seem like it's a lot more. Mental health issues, mental health problems, diagnoses, affect in a given year about 26% of the American population. Depressive disorders themselves, so a thing we call major depression, which means clinical depression, bipolar depression, dysthymia, which is kind of a mild, ongoing depression. That'll affect about 20%, 18.9% in a year. So there's many that are higher. In fact, I read recently a good study, and that said approximately only 39% of children with ADHD get treatment, and only about 11% of adults. So it's not overdiagnosed, and it's certainly undertreated. And that's one of the things we'll want to talk about is the treatment of it. Some of the difficulties that, and I'll just go through these a minute. There's a thing we call comorbidities in ADHD. What happens when we have ADHD? What are some of the problems? Well, one is about 50% of people that have ADHD will have some level of what we call comorbidity. Two things happening at once, two problems. One is ADHD. Well, what else? Pardon me. If I have an attention deficit disorder because of the wiring of the brain, or as a result, the wiring of my brain also makes me, and maybe some of my interactions or frustrations I have out of that, makes me have a 50% greater chance of having depression in my lifetime. Another disorder that can happen about 30 to 40% of the time with attention deficit hyperactivity disorder is a disorder called oppositional defiant disorder. Sounds like a lot. Again, it's pretty self-explanatory, but a fairly serious disorder. It's more of a problem than the ADHD is. Oppositional defiant disorder means I'm oppositional, tend to be defiant, I tend to see the cup half empty rather than half full. In both disorders, because again of brain functioning, there'll be some level of irritability higher than the norm, or more than most people have. With oppositional defiant disorder, there's a great deal of that. The brain is structured so I'm irritable, severe temper, so it causes me significant problems not only in the home and with parents, but in school, socially with peers, those types of things, which then again increases chances of depression. Another comorbidity is the anxiety disorders, including obsessive compulsive disorder. Obsessive compulsive traits are not uncommon in ADHD. Or social phobia, so that I have significant, we'd perceive it like significant shyness, or I have much difficulty standing up in front of people and talking. Tend to not want to socialize much. So all those comorbidities are present. Learning disability is 50% chance if I have ADHD, 40 to 60% chance. And these can be two types. One is a specific type, which means I might have a reading learning disability, might have a math. The reading would be over here in the left hemisphere, the math over here, about right there. Writing learning disability, whatever. Again, if that's undiagnosed, significant problems, because that again is treatable, significant problems will exist. So all those types of comorbidities are there. What research shows, and we're talking now, when I give some of these statistics, the old bell curve or the average, okay, when I'm talking about what happens to ADHD people more, I'm talking about the people here. There's plenty of people that have ADHD, how can I explain it? That tend to achieve, and there's difficulties that they have They tend to achieve. They tend to not have a lot of behavioral problems. They tend to socialize pretty well, those kinds of issues. And there's ones that have much more severe problems than I'm giving for the average. But the average ADHD person, or the population, why it needs, another reason we have to do the treatment, is it tends to, ADHD folks tend to have a lower income because of lower educational achievement, but also because of work difficulties. I've had many times where I've had someone in my office that scenario goes something like this. You know, they're at the job now 6 months or 4 months, just got out of school, and the boss calls them in and says, you're just not working hard enough. You're not getting things done. You're inefficient. I'm really concerned about your work habits. The person will be hurt because they'll say, you know, I've been just busting my butt. I go in on Saturdays, I work extra hours, and they really are giving that effort. The problem, again, is the inattentiveness, see, and the inefficiency that's there with that. Also had it a number of times when these people got on medication to direct that attention better. The boss will say, you know, about a week after I talked to you, your behavior was totally different. You know, again, the people are thinking that it's a choice. So income issues are there. Speeding tickets, arrests, 13% greater than the population, I think it was. More arrests, speeding tickets because of the impulsivity. 10 times the average unplanned pregnancies in the ADHD population. So what's driving this? Well, there's 3 things that we really look at in ADD. One is impulsivity. Okay, when I'm going to give up on this one. I'm not an artist, so here's the brain, okay? This area up front, here's where our learning takes place. And we're going to do a quick down and dirty neurological lecture here. This is the left hemisphere of the brain. This is the right. I'll get into these shortly. But our learning's taking place in here. Okay? This is the brain stem, goes down into our central nervous system. This area here, right here, is called the prefrontal neocortex. And what that does is our executive functions. So we take information from here, we bring it up here, and this is where our planning is. This is where our ability to organize is. This is where our abilities to make judgments is. This is where our attention abilities are, concentration, distractibility, all those areas. So what's not uncommon in ADHD is that these 2 areas, this left hemisphere, this right hemisphere, when I do psychological testing, show me they're working just fine. They might be in the normal range, both of them. They might be above normal. They might be in the superior range. These are fine. But there will be a dramatic difference between how the numbers I get here to the numbers I get here. You understand what I'm saying? So this is functioning lower. So impulsivity is up in front. So I can have pretty much some best intentions, but I get in the wrong situation and I become impulsive in a hurry. I do first and I think second. That's a vulnerability. Now, people that have the inattentive type, back to that, will tend to show less impulsivity. But again, to some degree, it'll be there. All right. Distractibility is the other feature up there, or in ADD, another feature that's up in that front part. That's the issue of, that can happen two ways, or a number of ways. I can be sitting in class and giving good attention. Something happens over here, somebody talks. That extraneous stimuli just pulls me that way. Bird flies by the window. Driving, that's what happens. Time and again, the speeding tickets will be from the person either busy listening to music or talking to someone, and suddenly it's 85 miles an hour down the expressway, and they're getting pulled over. That type of thing, the distractibility. Then the other is inattention, which, again, I can be looking at you, and we can be talking, and let's say we're at a party, and someone's talking here, and I can be pretty interested in what you're saying, but what easily happens is I'm listening to this too, because I'm getting distracted, and then due to the inattentiveness, I'm listening to two at once. Those types of issues. Are there any questions thus far of anything I've talked about? Yes.
Earlier you were talking about, you said something about 60% of children when they go into adulthood either do or don't. Which one was it?
The question was basically how many people in adulthood still have ADD, right? About 60%. So of 100% of the children that had it, 60% will show significant signs of it. And that's how it affects them. Yes?
Have you done studies on adults who have ADHD who pass on to children, or is it very genetic?
Question is it a genetic issue? Is it passed on? Current research shows that likely 80% of ADHD has genetic loading. So parent or someone in the family likely did. What other factors are there in that? What else could cause it? We know from developmental histories, this is a very important thing in terms of developmental histories, a very important, one of the important processes when you make a diagnosis. I'll take a developmental history and say, tell me about your pregnancy with your child. And if we have, there's different markers in pregnancy that show us, I'm not going to say it differently, that when they're there, we have ADHD much more often. And that can be things such as spotting and bleeding during the first trimester, other difficulties with the pregnancy that the mother has that just caused some degree of abnormality or abnormal functioning. Birth trauma is a pretty big one. Cord wrapped around the neck, need for oxygen, difficult labor, difficult delivery. It's like it doesn't take much for something to happen here. It doesn't take much for any brain injury to occur. But it doesn't take much. This originally was called, when I was in college, this was called MBD, minimal brain dysfunction. And kind of a weird term for it, but in some ways it summed them up. It's not a big trauma to the brain that's happened. It doesn't take much. Or we have the genetic factor. I had someone had a question about that when I said that.
I had a question.
4 to 1, about 4 to 1 males. Many disorders will be about that number. It'll be a little higher for some. Typically occurs more in males than females. I think there's a couple of reasons for that. Most females are born stronger. They, in utero or during gestation, they are less susceptible to insult to the fetus than males. And why is it? Well, there might be a number of reasons. One is in most of all species, the females reproduce. They keep the species going. So they're likely set up to be stronger that way. Women tend to live longer. Females tend to have a longer lifespan than males. So those kinds of issues tends to be more. The other issue is males tend to get diagnosed faster because, think of cultural issues, because of activity levels. Also in girls, that the ADHD will tend to show up more in the inattentive type. And I think a girl has to be, often what brings a child to my office, or certainly in the past, it's less so now, was kind of continued behavior problems in school. So that parents got to the point, or the teachers did, that said, this person has problems, so you have to get this checked out. Females will tend to have less of that. So I think it could be a little higher for females, that might be even more underdiagnosed, but it's not likely to be a 4-to-4 ratio, you know, type of thing. So, yes?
When a child is diagnosed, do you do any post-assessments to see, like through adolescence and adulthood, like what the changes are in terms of levels?
I try to, and yeah, I do. But when I say I try to, it depends on the person and if they come back and as I'm seeing them.
Do you see a decline?
With treatment, what you typically see, you mean a decline in less attentive problems, attention problems? Yes, yes. With treatment, you will see that. Formal testing doesn't always bring that up, doesn't always show that, but reports will in functioning. Okay. Let me give you the diagnostic criteria a minute, and then I'll get into some how we diagnose it. Okay. What we need to have to make a diagnosis of ADHD is of these 6 or more of these symptoms. In terms of distractibility, doesn't pay attention to details, makes careless mistakes, difficulty paying attention, does not seem to listen, difficulty following instructions, does not finish things, difficulty getting organized, avoids doing things that require a lot of mental effort, such as homework, loses things, easily distracted, and forgetful. So for the inattentive type, we need those 6. Okay? Any questions on that? All right, for the hyperactivity type, and we'll include impulsivity in this, we need fidgets with hands or feet, squirms in seat, difficulty remaining seated, difficulty playing quietly, on the go, acts as if driven by a motor, talks excessively, difficulty awaiting turn, interrupts others or butts into their activities. Now, just to make a diagnosis on that is, I think pretty tenuous. There's a number of things that can cause those types of things. Anxiety will do many of the things we just talked about. If my anxiety level is high enough, a number of those will happen. Okay? Other issues. So, what do we need to do to make a good diagnosis? Let me back up a minute. One of the treatments that's often done today is child goes to their pediatrician, mother takes them to the pediatrician, and they're diagnosed with ADHD, and they're put on medication. And that's kind of the extent of it. Okay. you might have pretty high rate of correctness in there in terms of that child having ADHD. You might not, depends on that pediatrician. They're not specifically trained in mental health disorders, okay? But the person might do all right with that. The problem comes in that that's just one small part of the treatment. We've missed the learning disability. We've missed the other possible comorbidities. But also the person is not finding out what to do about this. How do I compensate for this? How do I write this so it's not such an overwhelming issue for me? That's the important thing. So back to the diagnosis. Okay. We need to have those. But what we also need to do is to have a good developmental history that says, do we have any of this in the family? Do we have any of that? How was the pregnancy? What kind of behaviors do you see? It's good to have teachers fill something out. Not always necessary because teachers have 20, 30 kids in their room, and especially kids with inattentive type then can be missed. But it's good to have as many different areas you can. What is best, in my opinion, and I think is often more than my opinion, but is psychological testing that shows these areas again, okay? Various tests that are showing how these are working. Let me give you an example of what happens. So I do psychological, I have all that information now that we've just talked about. And then I do the psychological testing. And I find that this part of the brain, the left side, which is the verbal area, our entire language system's on that side. So reading comprehension, everything in that area is on that side. Let's say I find out that that's at overall, there's a number of areas that make that up. That's at the 60th percentile. I'm going to put all these together. And the right, which we call the perceptual and analytic, because that's what we do. We perceive, we analyze, we sequence events, we do a lot of the math over there. Logic is over there. Things like art, science, computers, those kinds of things. Let's say that's working at the 59th or 58th percentile. Though these are those two hemispheres, and they're connected. So we do a lot of things on one side, but we employ both. When I read, 90% of my readings here, 95, 98. I flip over here for a millisecond visually, because this is a visual side. I decode the word. Okay, that's what that word is. And I'm back here with the meaning of it. So we need these to work together, okay? They should be within a certain percentage of each other, or we have what's called statistical significance. Then I know, like at a 98, 99% chance, we have a problem here. Okay, what's pretty typical is that these two will be really pretty close. This area, again, this is that executive area, okay, number of tests, and that should be then, like in this area, within statistical range. But might be 31%, might be 18%, might be 11%, okay? So then that says to me, we know we really have a problem here. So there's a battery of tests that you can give that show how that executive area works compared to these other areas. Often when I do this test, or at times when I do this testing, one of these areas, maybe right here, like I was saying earlier, maybe an entire side, maybe here, will show me that we have a learning disability too. So if I just go and I get medication for this, I'm missing out the extent of this and what we need to do. I'm missing out on any learning disabilities, which is going to be half of the problem. I'm missing out on anxiety issues, depressive issues, unless they're strong enough or they happen to come out during my interview. So that's how the diagnosis should be made. Yes?
I've heard that they're looking at the omega-3, 6, and 9 in the brain, and vitamin D levels, and vitamin D levels. If they're not where they need to be, that the brain isn't functioning as well as it could be. So that it's important for people with ADHD to have those levels in their brain.
Yeah, it's important for, I think, those levels to be there for everyone. If we have ADHD, I think we're vulnerable to more issues. But omega-3s, or fish oil, high-quality fish oil, has in certain studies shown to be effective with depression. To some degree, there's some thought that it has some effectiveness with attention issues, but not significant, okay, at this point in time. So,
I guess to have the brain operating at its optimal.
mhm,
So for
yeah. Over the years, I've watched a lot of things come and go of certain diet, okay. No food colorings, that was a big thing for a while. You know, those kinds of issues. None of them have held up to research. So what works? What works for ADHD? Well, let's look at the attention issues first. Psychotropic medication is huge today compared to even 10 years ago. So, I mean, you watch TV and you see antidepressants, anti-anxiety agents. You know, there's been, it's a big difference. And again, you can often feel that, well, maybe everybody's on these type of things. And what research shows with depression, anxiety disorders, those types of things, that many of the medications are very effective. It also shows that therapy for those specific things are very effective. And that in some cases, certainly with depression, with obsessive compulsive disorder, a good type of therapy called a behavioral cognitive therapy that addresses how to work with this is probably more effective than medication. There are a number of, or some times when both are needed, okay? I think most of the time when you do just one, it's going to show just medication, yeah, you probably get some improvement, but you probably won't really get the great improvement as you would with both. Now I say that because, so that's kind of the stance I take and what I see. When it comes to ADHD, I've seen nothing, and I've tried it myself in the research, nothing helped the attention more than the medication that's given for it. And typically the medication, you've all probably heard of them, but Adderall, used to be a lot of Ritalin, but Adderall, Concerta, Metadate, there's a number of them. What are they doing? Back to the front part of that brain. What we do know is that this area, if we light it up on a brain scan, is working slower than these areas. That's the way it works. And it's kind of counterintuitive, but the slower that works, the more hyperactivity I tend to have. The medication that's given is what we call a psychostimulant, a brain stimulant. So it stimulates this area. In this area, in all the brain, there's a number, thousands of neurotransmitters, brain transmission, okay? And we have different chemicals going through those. And those of you that have physiology, anatomy and physiology or something else in high school or now know that there's a synapse, right? There's fires across there. And there's different chemicals involved. Well, dopamine is one of them. And dopamine gives us attention. It also gives us mood, but it gives us attention and concentration. And what's happening is this is not being pulled, this uptake mechanism just isn't pulling that across fast enough, so it's working slower. So if we give a stimulant, a pill that stimulates the brain, it increases that. So that speeds up, and I slow down. Get it? So it's kind of just the opposite. So what's been shown to be very, very effective for attention is medication. All medications have side effects. It's a trade-off to some degree. And some kids have, and adults have more side effects than others. The other thing that's needed to treat this is, as in children, is work with the parents, and this is what works, this is what won't, this is how we can shape behavior, this is what will be successful with that. Work with the school, but then especially with the child. Because we have to address, here's what's going on. Okay? Again, too many don't get that treatment. They really, you say to them, well, why are you taking this pill? I'm hyper. Well, what kind of message is that sending? I mean, what's that going to do with self-esteem or self-concept? I'm hyper, So well, okay, so let's talk about that. Let's figure out what we can do about it. We can also really do great things in terms of learning how to achieve, so we don't keep running into this frustrating wall, so that we can continue to achieve. So it's what we call a cognitive and behavioral therapy, one that explains what's going on and shows how things can change and what we need to do. And those have been shown to be the best treatment. Ongoing basis, the question about do we see improvement then over time? Almost always we do, if that's treatment is followed through. And then maybe at periods of developmental shifts, we'll need to do a little bit of adjustment. So I go through grade school to high school. Well, that's a pretty big, or middle school. Here's what often happens. I'll have children come to me for the first time, and they're in middle school. And when I look at it, the symptoms were always there. They were strong, but they did well in grade school. They got to middle school, and boom, they kind of started falling off the cliff. Well, why is that? Well, back to one of the principal figures or problems in ADHD is difficulty getting organized. Okay. I went from having one teacher that said, now remember, tomorrow we have this, and kind of nursed me along, to 6 teachers, and I'm being distracted in the hall, and I'm starting to forget homework, and my hormones are kicking in, and all sorts of problems, you know what I mean? So boom, that happens. It's not unusual. I'll see somebody that made it through high school and did all right. They didn't study a lot, and they're smart enough to get away with it, but did all right. Go to college, fail. And that's how they'll end up in my office. Well, same types of issues again. You have to be more organized, more problems come up. One of the hallmarks of adult attention deficit disorder can be just a paralyzing procrastination, that we just can't seem to get anything done. Just can't do it. So different shifts like that might need, a couple of sessions of adjustment.
So if an adult is taking medication, are they dependent on that for the rest of their lives? And then also, if you see inconsistent use with medication, is that harmful in any way?
Many adults will find once they're about 24, 25, maybe a little older, some younger, that they don't need the medication, depending on what they're doing too, but for attention, that is improved. What we know now that we didn't even 10, 12 years ago, is this front part of the brain, this prefrontal area, with all those issues in it of judgment and all that, continues. We used to think, well, about 16 or 18, that was done growing. It isn't. Now we know that that keeps doing that right up to 20, 22, 24, 26 age. That's why teenagers can tend to make some horrific judgments, because this is way ahead of this. Okay, that's just the area of judgment. So, or you'll hear, you know, that person was, you know, hell bent for leather when they were younger. Now that they're 24, man, did they grow up? You know, well, likely a lot of that is because this hardened off. As that hardens off, then I might need less medication. So I'd say, I don't know, at least half of adults probably don't need that medication, and maybe need no medication, you know. In terms of using the medication, it will enhance the attention issues. And then you can go off it, summers or weekends. All those other issues will pick up, the attention issues and whatever. So it kind of, you can get away with taking it, but if you do it one day and then not, and then the next, you're going to always be kind of having some side effects. But, you know, if it's mostly inattentiveness, you likely can get by with taking it during the school week. If it's more than that, it's probably affecting you socially, it's probably affecting you behaviorally, and you're probably better off taking it all the time. So a number of kids that take it, that their anxiety also goes down once they can attend. And if you think about it, that makes sense. I mean, if I have 10 thoughts going through my mind at once, I got a greater chance to become anxious about something than if I'm focused on something. So. Okay, that's about all I have. Any other questions? Yes? Okay. The question was, what percentage of the population is misdiagnosed with ADHD, right? It's hard to give a percentage on that. There's a few areas. I mean, if I have anxiety and I'm showing some signs of inattentiveness, could be, you know, misdiagnosed as ADHD when it's inattentiveness. Medication, or if I have bipolar disorder, it used to be called manic depression, and that can be a tough one because some of those symptoms are the same. Often, and that's a very inherited condition also, and if I have bipolar, I will also have attention problems. And at one point it might be ADHD and then move into that, you know. So that can be a misdiagnosis, and that can be a dangerous one because if you give a psychostimulant to that, it can grease the skids and make me manic. So, but in terms of, you know, people being whole-scale diagnosed ADHD when they aren't, I don't think it's a very high percentage at all. I think it's very low. I think, again, back to my earlier statement, there's many more people that aren't treated and aren't diagnosed than an overdiagnosis is made. So why is it that my school tended to have a lot of that, you know? A little misdiagnosis may be going on, maybe not, but it also could be the case that my school happened to have enough people that had the resources, had the abilities, had the insurance to get treatment. See what I'm saying? Where school B, that might not have been the case. It's not more in one population than another, in one suburb than another. It's 10%, 8% across the population. But certain areas will have more treatment done than others. Can it get to be a faddish thing? I suppose, but I don't think there are very many professionals at all that diagnose on that get caught up in that, you know. So, yes.
A couple times you use the term hardens off in talking about the frontal
Did
lobe
I?
developing. Could you elaborate on that?
That means maturing. Maturing. It's no more, one of the things you talk about in neurology and how brain functions is soft signs, the soft area of the brain, you know, that's not working quite as well. So that's kind of a slang thing, but it means it matured, it caught up and then matured. Hyperactivity, like I said earlier, can be, it's usually worse when we're younger, and that's because we're younger and our central nervous system is very undeveloped. And kids with ADHD, that can develop later, you see. So it's just development of it. Yes?
What are some of the serious side effects of medication?
Some of the side effects of medication. Some of the typical side effects of medication, and these tend to go down as time goes on. Not that they go totally away, but they tend to diminish some, as reduction in appetite, maybe some insomnia the first few nights I take it, more difficulty falling asleep, though with ADHD and adolescence and early adulthood, falling asleep can be a problem too. Headaches, stomach aches, elevates the blood pressure a little bit. At a young age, that's not necessarily a big concern at all. Elevates the pulse a little bit, those types of things. We can have what we call a rebound effect. And that's basically this, is I've pushed these symptoms, first of all medications have side effects. Aspirin has side effects, but we've pushed these symptoms down for the day that we've been on the medication, okay? And it has about a 10-hour half-life, it's called. So it lasts about 8 to 10 hours. And then it's out of our system, and that's why it's not addictive, okay? If I take certain stimulants that don't have a half-life, they're highly addictive. All right, like methamphetamines or like crystal meth. Okay. All right, I've pushed these symptoms down. Now I'm going off, and the symptoms were this big to begin with. I went like this. When I come off, I'm going to like this. So I might be more irritable. I might have worse attention span. I might have more hyperactivity than I did for an hour or two. Then that'll go down. So that's about it. Yes?
I just wanted to ask about the brain imaging. Is that a routine part of the diagnosis then when you see someone in your office?
It's routine, yeah. For me, it's typically routine. It's not, I mean, it's not that this is done routinely in making the diagnosis at all. I think it should be. Now, it depends on, a lot of it depends on what the people can do. It's not a cheap procedure. So it depends on their insurance and that type of thing. So then you go to the second line. I might do a smaller amount of testing and say, here's what I think. But the more you get to just checklists, here's like a typical checklist that I'm checking on, and I say, okay, that's enough, we got a diagnosis. Well, one of my partners is, in the practice I'm in, is a psychiatrist. Here's a typical thing that happens. This patient came in to see me. I gave her an adult ADHD symptom checklist and did a bunch of other stuff. Didn't do tests, did one small test because the issue we just talked about. Had it in the chart. It was under a progress note. I sent her after a while to my partner's psychiatrist. He used the same checklist. She fills it out, and he says, okay. And I looked at them later. I happened to come across them. They're totally different. See what I mean? There's no standardization to it. So it's not that scientific. It just can't be.
And then my other question was about the amygdala, because I know the research, like in the teenage years, the amygdala is very interactive, and I've always sort of described that that's why teens are, part of the reason why they may be more impulsive. Do you know how that fits in with ADHD?
Yeah, I would say that, well, the amygdala being and causing aggression and those types of things is kind of across the board. I don't think that, as far as I know, I don't think you can find any studies that says, well, the amygdala in ADHD is a lot different than those who don't have it. But what we do know in ADHD, that this area is a lot different than this area. Another question here somewhere? Yes?
Can you review exactly what tests you use, like the behavior rating scales or TOVAs, or what tests do you actually use to do a full comprehensive like testing piece?
Yeah. In terms of the standardized psychological testing that I use, I will tend to do either the Wechsler Intelligence Scale for Children, which shows how everything's working up there, or the adult version of that, or the Woodcock-Johnson test of cognitive abilities, which shows the same types of things. Typically, I add to that test of executive function, which might be one that's called the London Tower of DX. You have to do certain things. Wisconsin card sorting test. All these things show, so I'm getting back up that, yeah, we certainly have problems here. And then I give a good test for learning disabilities, typically the Woodcock-Johnson or the Wechsler achievement test. An in-depth one, not a short, because time and again I'll find, one of the things you can just find from that is like in the area of reading fluency, how fast do I read? Well, here it's showing up again, you know, that you can't read fast. Well, that has to be with everything we're putting together now, an attention problem. So, but it's not always possible to do all those. That's the best way. Yes?
What's the likelihood of somebody diagnosed with having just mild retardation? Do they always have, attention problems? You know what I'm saying? Can they have both?
No, I think you could have, cognitive impairment and not have attention problems, but the majority of the time you will. Okay, but then we have more of a global problem. We're not just a problem here or an N+1 here or something. We have, so everything's functioning, in an impaired manner, so.
The most severe case of ADHD, is it always medication? Is there ever a time when you cannot control it with medication?
No one with ADHD has to take the medication and, how can I say this? It doesn't mean that, I'm doomed because I'm not taking the medication. It does mean, and what I'm saying is I'm not a tremendous advocate of, okay, let's throw a pill at whatever we see going on here. I'm more of, well, let's try to figure this out. But what I am saying that research clearly shows, and my experience clearly shows, is it won't be as effective, the things I work on with you in terms of let's improve your attention, I won't be able to compete with the effectiveness of the medication. Just won't. So, no, you can certainly work without it, but it's likely going to, especially in terms of things I talked about, academic achievement, work achievement, those types of things, it's likely going to be very helpful. Yes?
Can you talk a little more about what you do in therapy as far as promoting attention and what you tell parents?
Yeah. I don't do a lot in terms of promoting attention other than pointing out that, what I'll do is at whatever level the person's at developmentally, do this picture. So I might do a 5-year-old level or I might do a 50-year-old level. But so for the children, what I'll point out is that because of this issue up here, that's why you're hyper, you know. That's why you have problems paying attention. And what we're going to do is work on that, because here's the problems it causes you. And they can relate to it immediately. You know, you will get in trouble with the teacher because you're out of your seat again, and you didn't plan on that. You blow up at recess, and kids start to pick on you because they know you're going to have a temper tantrum, and it's like, hey, let's have a show. Those are the ways I work on them. Why does that happen? It's because of this. What can we do about it? We need to learn that that causes this problem. See what I mean? If you come to me at 7th grade and you have no idea about ADD, really, and you've gone from fairly good grades or whatever to really poor grades and having more social problems or whatever, or you've had that the whole lifetime, you're not thinking, hey, it's because of my attention issue. You're thinking it's me, right? I'm not very smart. I mean, I hear that all the time. I'm really not very smart. Well, guess what? You are, you know. Or I'm not, or this or that. You see what I mean? So what the treatment has to be then, no, that's not true. That's not the issue. The issue is this, and here's what we do. We have to learn to be organized. We have to da-da-da-da-da-da. And that's the same as you work, same that you work with the parents, same issues you work with the parents on, how to promote that and how to promote them becoming more independent, the child, so the parents not doing all the homework with them every night and fighting over it and all these issues. That's the same for a parent. If I understand that my child has this problem versus he's just, I thought he was being a spoiled brat, that's a whole different deal, you know. It's a whole different way of treating the child then. Yes?
What are your thoughts on giving the medication to very young children, being able to
I guess quickly what my thought would be is, unless it's dangerous hyperactivity, you know, and it's just causing them incredible problems, I'd try to wait it out. It might mean they're behind somewhat academically, but at that age, you know, we can catch up. Where it can become a problem, and I've seen this kind of issue, is when it becomes dangerous, when there's so much hyperactivity that, you know, he's always running, and he runs into front of a car while we're in a park, and, you know, those types of things. So, but yeah, right.
I don't know if this is a question or a comment or both, but I just read 2 studies in the last few days which were looking at the switching function of the prefrontal neurocortex. And it was looking at the juxtaposition between depression and ADHD. And in one case, as you described with ADHD, it's inactivity, where depression, it's a hyperactivity. It becomes depression when you start perseverating on a single thing. But what was interesting is a secondary study that was built off of that, and this is sort of relating to the people in the room, which was looking at multitasking.
Mm-hmm.
And it was showing that when students multitask, they are exhibiting the same learning qualities as a student with a person with ADHD. That in fact multitasking, meaning using texting or listening to music while you're studying, it actually increases the error rate by 50%.
Yeah.
And it decreases the amount of information that is acquired by 50%.
Right.
So you get half as much information, but at least the half you get is wrong. And so it's just that idea that we can exhibit behaviors, and I guess sort of speaking to the issue of therapy, that our behaviors do play into our ability to focus and acquire information.
Oh yeah, and exactly right. You know, there's a number of studies showing that multitasking reduces attentiveness. Okay, and also it can reduce attentiveness a significant amount of time with television or video games. Doesn't reduce it permanently. It'll come back up again. But the more I'm doing that, if I do that all day and then I take a test that night, I'm going to be less attentive than if I didn't do that.
So what would you suggest as a learning environment, back to ADHD, what kind of learning environment would be
Well, practically, it means that I sit in the first seat, because if I'm sitting in the back row, if it's all reversed, I'm checking this person out, checking that person out, I'm watching somebody do this, I'm looking up at this, I'm going to be more focused, you know. So front seat or close to it. The school needs to know. I need to likely have extended time. You know, you have that set up here at CC. I do that all the time. I get some extended time on tests. That type of learning environment. The bigger the class, I think, the more chances there are for distraction. So.
And what about behaviors then when they leave the class? What should their typical evening look like, their typical day to be a high-performing student?
I think you're going to have to, what works best, what I see works best, that you get into a routine that this is when I do schoolwork or work. Because otherwise what's going to happen is procrastination. You know, one of the difficult things to get a kid to do is to start finishing homework. And the same goes in terms of study habits, and I think, in college. And then a lot of times I'll get a kid to hit, okay, we now have it to the point that he or she is finishing homework. And I'll say, great, you know. And then next time I see them, they're in trouble for not turning in homework. I said, well, I thought you were getting your homework done. Well, I do. I just forget to turn it in. Okay, so all right. So then, you see what I mean? So it has to be structured. I think there has to be a structure that every night, this is the time I study. Otherwise, it's not likely going to happen. I'm going to say, well, okay, I'm going to study from 4 to 6, but, you know, Jimmy showed up, we're going to go play some ball, and then I'll study from 7 to 9. And then at 7:30, man, it's a nice night out. Friends are going out. I think I'm going to do that. See what I mean? It just does that kind of thing. So we just have to set it up that way. Otherwise, it's probably not going to happen. That procrastination is just, and organization abilities are just they're too weak, and procrastination too strong. One of the things that I find works very well for people that have attention problems, whether they're in high school or college, is I can read this chapter 5 times and look at what's important in terms of what's in italics, or, you know, what this definition is, or what I've underlined. Or I can look at those things and type them on my computer or write them out longhand. And I can do that once. I'm going to know it better than when I did that 5 times. And that's because I directed my attention. And I'm doing something. I'm being active. It disallows me to be as distracted. So that's one that really works.
There are a lot of people who have to listen to loud music and it helps them focus. How does that work?
Yeah, that's a good question. I think what it ends up doing is it's a combination of it's some action going on and cuts down distractions. Because there's some kids that with ADHD and adults that really can do that. The only time they really, not only time, but they study better or read better when they got music cranked. And there's others where there's not a chance they're going to get anywhere with that. So, I don't know, but I've observed that. Yeah. Yes.
Between the mild, the moderate, and the severe, who typically has the most problems in the later adulthood?
Severe. Yeah. Because first of all, there's just this really overflow of activity, which means tends to mean I'll tend to be highly impulsive, which means I'll have more speeding tickets, which means I might get enough and I still got to drive somewhere, so I'm going to try to drive without insurance and without a license. See what I mean? So it's mostly because of the high level of hyperactivity and the impulsivity. a lot depends too on the treatment. ADHD, we have, when I told you the comorbidities, I guess one I didn't mention is a much higher comorbidity of substance abuse. Okay. It's a self-medication thing. I'm kind of built for the fast lane, so hey, you know, this helps. THC, component marijuana, will immediately give me a little better attention. Problem is the side effects. I mean, it's, you know, the next day my attention is worse than it ever was. But so, and if I'm not getting another treatment, alcohol, same type of thing, at a low level. So, it makes me more susceptible to that. Substance abuse and depression, those two then tend to cause more and more problems. Most suicidal behavior is person either depressed or substance abuse. Okay. Have a nice day out there.